regards. My name is Michael Fine. I'm the Chief Health Strategist for the City of Central Falls. And I thought it would be a good thing to go around the room and have everybody introduce themselves so I know who you guys are. Let's start with you.
Ryan Bradley.
Right.
Timothy Kelly.
Okay.
Michael Rodriguez.
Good first name.
Andres Nunes. Dan Patrick.
Wilson Milano.
In the back.
Paul Chalmers.
Ryan Griffin. Sean Mankenberg.
Jeff Sylvester.
Mark Landry.
Sean Gogan.
Mike Ranga. Scott Padilla.
Lieutenant Russ Blanco.
Brandon Dunlap. Keith Williams.
John Garvey.
DLA. And
Welcome everybody, I'm glad you're all here. We're here to talk about mobile integrated care. I'm going to stress the word integrated because that's what this is about. This is about the integration of EMS services into the rest of the healthcare enterprise. I learned about this first, when you get right down to it, in 1979 or 1978, probably before most of you guys were born. When I was working as an organizer in the South Bronx, and in a world where there was no more healthcare services. There weren't pharmacies, there weren't doctor's offices, there wasn't much. And so we started actually by building from the ground up. I mean, most of the Bronx was burned out then. We started by building an EMS service. So I actually started my professional life as an EMT and then teaching people to be EMTs. And that was the basis of how we rebuilt healthcare in the South Bronx. I want to just, for a second, introduce my colleague, Dr. David Sam. Excuse me? Dr. Sam, come on in.
How are you?
He is the lead physician at Blackstone's Express Care Service.
Our lead.
And he's going to be a very important person on the Blackstone side. Is there another chair we can find, Dr. Sam? You know, we don't, Dr. Sam's not going to stay very long, but I just wanted you guys to be able to meet him so you had a name, a face to put together with the name on the other end and the voice on the other end of the phone, because that will happen as we unroll and develop this relationship. So I started in the South Bronx. We started building EMS services first. Now flash forward to probably 2012 or 2013. I'm working at and trying to run the Department of Health, and I get a call that I need to go to West Dewey Hospital because it was in trouble. So I walk into West Dewey Hospital, and the president walks up to me and says, "You, what are you doing here? You're causing the financial distress of this hospital." And I said, "What? I got nothing to do with financial distress of this hospital." He said, "Yeah, you certainly do. You know, you guys changed the regulations so that people with SDT wave MIs have to divert around this hospital. That's cost me $1 million worth of business, and we're going into the red, and we're going to have to be sold. And it's your fault." And at that moment, I understood that EMS was at the Department of Health, which I actually hadn't understood before, because I was just new, and began to understand how important the role of EMS was in the healthcare system as a whole, how EMS in many ways shapes that system. Now I'll talk in a little bit about why integrated care is important, but the thing that I wanted to make sure of was that everybody understood the integration side, that this is particularly important because we're trying to figure out a way to build a healthcare system that actually takes care of everybody and does it in a way that's affordable. Now, before I jump in and talk about primary care in Central Falls, I want to talk for a second about one of the overriding drivers. I think I'm going to mention it again as I go through. One of those overriding drivers is the cost of healthcare in the United States. Anybody know what it costs per person per year to provide healthcare in the United States? Anybody want to guess?
$12,000.
12,000? You are as close as I've ever heard
About 50.
anybody.
Good with numbers, Sean.
It's about
That's because he
11,000.
put a bet.
But most people have no an idea. So that means in the city, for people in the city of Central Falls, we are spending about $200 to $210 million a year for their health care. Most of that escapes from the city and can't be used as part of our economic development. Part of it, most of that goes into the pockets of somebody else. Even worse, when you think about it, and when you look at other countries and what they do and how much it costs and what their health outcomes are, other countries spend half of what we spend, $4,000 or $5,000 a year. That means if you really think about it, about $5,500, $6,000 per person per year is wasted and comes out of the system as profit, or profit for folks who probably have plenty of money already. And that means that for everyone in this room, and for everyone in this city, and for everyone in this state, and everyone in this nation, somebody's effectively used healthcare as a way to lift $5,500 per person per year out of your pocket and put it into theirs. And that's what most of us are trying to change. You know, that's money that ought to be used for education, for housing, for community development, for public safety. But it's money that is just being, if you will, forgive the word, pissed away. And those are the things that we're sort of thinking about trying to change. Now, the primary care world, I've had the opportunity to be a little bit in both worlds. The primary care world is pretty different from the EMS world. And we're going to talk about how that's different over the next week. We're going to use presentations by some of the most respected primary care clinicians in the state, certainly folks who are well known in the state, some folks from Blackstone, some folks not from Blackstone, but people are going to come and help everybody here get a sense of what I'll call the battle rhythm of primary care, which is a different battle rhythm from EMS. The battle rhythm of primary care might be called kind of slow medicine. We're there to make sure people don't get what they don't need, and we're there to make sure people get what they need when they need it. So we do a lot of getting people better, but we also do a lot of making sure people don't do stuff that's dumb, and do stuff that's dumb because somebody on television told them to do it. It is a very different battle rhythm, because we're not involved with trying to keep people from dying tomorrow, because most of the time we don't have the capacity to keep people from dying. Well, we have the capacity to keep people from dying in 3 days, 3 months, and 3 years, but we don't have the capacity to keep people from dying today. And what you guys have been about, and have been about incredibly effectively, is making sure that somebody who is sick this moment isn't going to be dead in an hour, 5 hours, or a day. And it's that difference that ends up being most significant. And the partnership that we envision is a partnership that says, let's keep our focus on making sure that people who are getting ready to die today don't. But let's also make sure that people who aren't getting ready to die today get appropriate care and do it in a way that's affordable and effective. Let me give you a little example about how that works. How that works when you talk about back pain. Now, I would imagine that you guys get occasional, if not many, calls for people having back pain. There are a couple of dirty little secrets about back pain. It's among the most common presentations of illness that we see as a nation. About 30% of all the people we see in primary care are people with back pain. The good news is that back pain can be easily treated, and it's best treated by physical therapy for most people. And it very, 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 very rarely leads to an immediate threat to life. But here's what happens when somebody with back pain ends up in the emergency department. For some funny technical reasons, it's almost impossible for people for physicians in the emergency department to order physical therapy. And yet for most back pain, physical therapy is the treatment of choice. So you'll hear more about this later. But so what happens for people in the emergency department is, for some funny technical, mostly malpractice related reasons, most people with back pain end up being referred to orthopedic surgery or neurosurgery. Now, the good news is that not that many of them go, but of those who go, 44% end up with a surgery. But surgery rarely works. In fact, a fair number of people who get back surgery end up with chronic back surgery syndrome, often end up crippled by the surgery, despite everybody's best intentions. So we have kind of created a great sucking sound in which we, sort of vacuum up everybody who has back pain if they call 911, and bring them over to the ED and put them in a situation where they are actually relatively unlikely to get the correct treatment. Dr. Sam, do you want to give any comment about what I've said so far, you being the person who sees most of this on the front line?
Yeah, back pain is definitely a very common complaint in the office, and yes, physical therapy is much needed for most back pain. Obviously, if it's anything traumatic that needs to have an immediate X-ray or has debilitating neurologic signs, like you have weakness in your leg because of it, then you would have to get an MRI treatment. So those tend to be the more serious back pain issues.
And Dr. Josh Gutman, who will be talking about back pain later in the week, will go through that in great detail. But we actually have the ability to get most back pain better reasonably quickly. But the way to do it ends up being, by and large, the outpatient environment, for better or for worse. So let me take you through some stuff about primary care and how it works. And then we'll talk a little bit about the draft protocol that we've worked out around mobile integrated care to give you some framing about how we think and how we're going to go forward. In front of you is a binder with these, for most of you, we had a bigger turnout than we were expecting. So we're going to work on getting enough for everybody in the next day. So for most of you, you have a binder that lets you, it will have these slide presentations in the binder. And there's also a book called Where There Is No Doctor, which is not about our environment. It's really was written for places where there are no doctors in rural parts of the world. But it has two advantages for us. One is it gives you a sense of how many of the people we get to take care of together view health and healthcare, because they come from places often come from places where there are no doctors, so they're not kind of used to what our scenario is. And the other thing is, it's a fairly direct way to think about health and healthcare, and primary care and the world as we experience it. It has some really smart lessons in it about just how we think about things that we thought it might be valuable for you to have. All right, primary care in Rhode Island. So why does anybody care about primary care versus hospital care versus emergency? So as I said, we spend about $220 million a year in healthcare. We keep about $10 million of that in the United States. In Central Falls itself. And most experts think we spend a third to a half of what we spend is spent on the wrong health care, and that's money we ought to be able to use for other things. In Central Falls, as we look at it, about 60% of emergency department use is ambulatory sensitive. The state number is about 50%. By ambulatory sensitive, that means could be provided in a primary care setting. Lots of people who do health policy argue about that number, but I think it's a number that's widely understood and agreed on in most of the world. The challenge is that sometimes it's not possible to know what's ambulatory sensitive when you see it the first time. And it's easy to look back and decide what could have happened in a primary care setting. Anyway, we have about 300 runs a month. We figure about 180 of those runs are ambulatory sensitive. The average emergency department cost for each run, and when you get to the emergency department side, is about $2,000. Those are national numbers. So the potential monthly savings to somebody, not unfortunately to the city, is $360,000, or about $4 million a year. So that's money that's coming out of everybody's pocket in tax money that's being wasted because we're not yet able to make sure that everybody who could be taken care of in a primary care setting is taken care of in a primary care setting. Now, the opportunity that we have is the opportunity provided by the new neighborhood health station in Central Falls, which provides this opportunity to provide the right care at the spelled wrong right time and right place. The new neighborhood health station, 47,000 square feet, will have, when it's fully staffed, 10 primary care physicians, I estimate 4 to 5 express care physicians, a whole bunch of nurses. We're all likely to be better looking than me. A bunch of dentists, mental behavioral health people, physical therapists, lab, x-ray, what am I leaving out? Substance use disorder treatment people, basically 90% of what the people in the city need in one place, and when it's fully up and running, it'll probably take 6 months to get there. We expect it will be open from 8 o'clock in the morning till 8 at night and open on weekends. So it will be present, it will be open, there will be a fairly robust express care, which sometimes people call urgent care opportunities, so that express care will be there to take care of people the same day when they're sick, without appointment. Just walk in and get your body taken care of. And we expect that will actually develop a fair amount of traffic from the city as a whole, and may actually change the dynamics of what people call 9114. One of the things that we are going to be doing, we haven't figured out who's going to help us do it yet, but we have a little money that we're going to take and start explaining to the people of Central Falls what to call 9114 and what to use the health station for, so that people know what's what. Because one of the things we've realized, and I think you guys understand this every day when you're on a call, is that most Rhode Islanders, most Americans, have no clue who to go to what for. Most people don't know the difference between a pediatrician and a pediatric neuropathologist. All most people know is it's a place. It's either got doors opened or closed, and most people don't have a clue about what you do there. And so part of what we're going to be doing is helping people get a clue like that, so they know before they pick up the phone what the right choice is. We're also developing some transportation options that will help people who don't need EMS level of care get transported to the neighborhood health station if they feel sick, because the numbers suggest that 22% of people in Central Falls don't have private transportation. My guess is that is an underestimate, and the number is probably greater, because we don't count, we don't have any data about people who aren't documented, and they're probably, everybody's guess is 3,000 to 4,000 undocumented people in Central Falls. So, primary medical care, dental care, mental behavioral health care, express care, lab x-ray physical therapy, multilingual staff. Now, one thing about community health centers that almost nobody knows, because almost nobody in the United States knows what a community health center is that community health centers take care of everybody regardless of insurance or documentation. One little kind of health policy detail that almost no Americans know, is there are 1,400 community health centers across the United States. They function at 9,000 different sites, take care of 26 million Americans. So community health centers take care of about a tenth of the population of the country today. And about 150,000 people in Rhode Island are cared for at community health centers. So in Rhode Island, community health centers actually take care of 15% of the population, almost 50% more than the national average. So community health centers are out there, and they've been doing this work for 40 years, and they turn out to be an important part of the whole healthcare environment, and have been the places that have been smartest and best about doing things like bringing mental and behavioral health into primary care, so that we have a whole bunch of colleagues who do mental and behavioral health. And they do all sorts of stuff. We've been doing all sorts of stuff, learning to do population health management, which means, printing out a list of all our smokers, calling up everybody who's a smoker, and trying to get them to find ways to quit smoking. We don't just look at everybody who comes through the door. We try to look at the population of the city and try to improve the health of that population by getting prevention to everybody. And actually, the thing that makes this neighborhood health station different from most community health centers is it will be the first in the country that takes responsibility for the entire city, not just the people who walk through the door. The old way of Blackstone, and the old way of all community health centers, was the only people you had to worry about was the person who got through your door. Now, we still have some restrictions on who we can take care of on the front end, but our job, as we see it now, is to enroll the entire city, so everybody can use what Blackstone has to offer. Dr. Sam, I don't want to hold you up too much. I know you've got patient care soon, so I want to say thank you for being here. Dr. Sam will be back on Wednesday, and will be our ear and hearing person. I'll tell you to talk about issues having to do with ears and hearing and so forth, so you'll meet him again.
All right, see you then.
All right, thank you, Doc.
So the new neighborhood health station has an ambulance bay that we're building in. Eventually, as I said, we'll have extended hours. We're going to walk you through it. I'll walk you all through it on Thursday. They are in the middle of finishing the construction. We think it will be online about the first of the year. And I had a sort of beg, borrow, plead, but we got the construction people to stop what they're doing when you come over on Thursday to take a look, because we want you guys to know it and to be comfortable with it and to understand what happens there and how it happens. This is the process of developing sort of us as a team, which is how we think about this. That, the new way of doing healthcare in Central Falls isn't one of us here and one of us there, but it's actually everybody knowing each other and working together. When we started, John remembers this, the first thing we started, and the chief remembers this, we used to meet for what we called electrolyte rounds, one afternoon a month, and hopefully I hope we'll get that started again. Electrolyte rounds have nothing to do with sodium and potassium, but don't fall. So, what is all this stuff about? So primary care is classically defined as first contact, comprehensive, continuous, coordinated, and patient-centered. A bunch of jargon if you ask me, but what it means is the primary care people are the people who you want to see first when you're sick. You want to make sure they know you as a human being and know you over years. You want them to know your family and your community so they know the world in which you live and understand what you might be experiencing and what might be going through. So the classic piece from my perspective is the piece that starts with somebody who comes in with a headache. Now, if that person went to the ED, that person is likely to get a CT and or an MRI. is likely to get a neurosurgical consult, might get a lumbar puncture, and will leave with a follow-up with a neurologist. And that entire experience would cost somebody $3,000 to $5,000 or $6,000. That person coming to their primary care doctor, first thing their primary care doctor says or knows is, or she whiz, what's going on in your life, and learns that, you know, this is a person who's taking care of a disabled kid and also is got, you know, a parent down the street who requires some help and support, and is working 2 jobs to make all the pieces fall together, and is sleeping 4 hours a night. And guess what? The reason they have a headache is because they're not getting decent sleep. And so we end up talking that through for a tiny fraction of the cost, because we actually know the person and know the person's situation. We get the problem solved. We bring them back a week or 2 or 3 weeks later to make sure the problem's solved, to make sure we didn't miss anything. But that's the rhythm of it. And that's the importance of knowing the person and their situation and their community, which folks in the ED just don't have the time to know. When you meet somebody for the first time, you know, you kind of move and move quick. But when you know somebody over time, you can help in a different way. The notion of being comprehensive means, you know, we're not talking about just one organ system. We're not just eyes, we're not just feet, we're not just heads. You know, we're sort of the whole picture, so that, you know, because guess what, the parts of the body turn out to be related, and so we're there to kind of sort it all out and put it all together, and then we're there to figure out if a person needs a specialist, needs to make sure they get to, we make sure they get to the specialist, we make sure we know who the specialists are that you can trust and those you can't. Not saying that any of my colleagues I don't trust, but some I trust more than others. Because I work with them over the years. I get a sense of who's who, what they do, how they do it, and why they do it. And for most of the people that most clinicians take care of, most of those people are known by their own clinician over many years. And I practiced sort of full service primary care for a long time. And I still walk around, you know, I run into people in the supermarket and so on and so forth. I still know the medicines they were on 10 years ago. You know, it's that kind of relationship. I'm doing express care now, so I don't have that kind of relationship the way I used to, and I really miss it. But that's what's built into the primary care process. And the patient-centeredness is supposed to mean that what our primary care colleagues are supposed to do is to sort of figure out what the person wants for her or himself first, and then figure out how to get it, instead of just saying, well, you got this, you gotta have that, whether you like it or not. Let me pause for questions or comments. Anybody have any? Anybody have a good primary care doctor they work with and trust? Nobody? That's a bummer. Well, maybe one of the things we can do by the time we're done is help people get hooked up with one, if you want to be hooked up with one. I know people all around the state, so not just in Central Falls, but this makes a difference. You know, they're writing about this all weekend. There's plenty of evidence that shows that places where there are more people using their primary care doctors, in those places, the outcomes, like how long you're going to live, life expectancy, is like 3 to 5 years longer. And you know, stuff like infant mortality is way smaller. You know, all the things that we want out of healthcare happens more when people have and use primary care doctors. Not one of
I have a question about
Please.
the average ED cost of $2,000
Yeah.
per visit. Do you have an assumption of what the average cost will be for a visit to your facility?
Yeah, it's about it's between $150 and $200. And most of that is, you know, if you have, unless you're fully insured, or unless you're quite wealthy, there's a sliding scale. So most people will pay $20 or $30 by the time the sliding scale is put on.
That would be considered their copay for the service?
Yeah, well, it's not really a copay, it's a sliding scale, which is a little different. I mean, if you have an insurance copay, whatever your insurance copay is, that's what you get stuck with. But if you if you're not relatively high income, and you have to pay for it yourself, then the charge gets slid down, and please don't tell anybody, but we're not really good at chasing after people if they don't pay. And we can't turn people away based on their inability to pay that day.
So how is the
But don't
program
discuss that,
funded?
okay? Excuse me?
How is it funded?
It's funded out of a mix of it's got a mix of funding. There's a basic federal grant that all community health centers get. That's why they're called federally qualified community health centers. So they get about 10-20% of their funding from the federal government. Then they get money through Medicaid. They get a better payment through Medicaid than most primary care offices get. So it's basically funded off patient care.
So
I've seen
how do you
patients.
propose to prosper when places like Memorial Hospital would have to close their doors for those same financial reasons? I mean,
Well,
how is it gonna work?
it works because the money that Medicaid pays health centers is enough to actually do okay on it. You know, this is based on patient care. Now, there's some, I don't know if you've heard this whole accountable care entity, accountable care center thing. There's this, I'm gonna try to save you the really twitchy and boring parts of health policy. But, everybody around the states is running around inventing these things called accountable care organizations. And the deal for accountable care organizations is that, instead of like Medicare and Medicaid paying individual services, they'll pay a certain amount of money per person per month to the care providing organization. And if that organization can figure out how to reduce the cost of care, then these organizations
So
get
how
to
is
keep getting
how can
money.
the fire department get in on that, some of that federal money? Because we need things here.
Like a rescue?
Right?
Yeah, like 2 rescues. I mean, we have needs probably greater than, what you're talking about. So this is gonna impact us. How can we get some of this federal money, or some of this Medicaid money, or some of Dr. Fine's money? Because really, I haven't heard anybody talk about fire department. But we're gonna be taxed more than ever, and we need equipment and vehicles, and
Well,
we need stuff.
I mean, part of the hope is that we'll reduce some of the stress on the fire department as we get this stuff up and running.
Yeah, that sounds great.
Well, we'll see if we can do it together.
All right.
That's the opportunity.
You said that the cost was a 150 sliding scale. Now, is that what the cost of the patient, or is that what you're billing to Medicare?
Well, Medicaid gets billed a certain number of dollars, and there's a really complicated formula that I'm not sure I really understand. So the cost of somebody with Medicaid doesn't have to pay anything. Somebody with Medicare has a copay. And somebody with, commercial insurance has a copay. And somebody without insurance has has to pay theoretically the whole freight, but they're often the people who get the advantage of the sliding scale. So if, we compute a price of $150 and you're on a sliding scale based on your income, then, you might get slid down, and often are slid down to that.
Well, what gets billed to Medicare is what I'm asking.
Well, what you bill to Medicare depends on the service.
Depends on who it is.
And, because Medicare, the way this billing thing works, everybody gets billed the same amount. It's what they pay the difference. And different organizations pay different amounts. And we have a crazy world, as I see it. So don't get me started on the health policy thing about how payment works, because it's all blinking crazy. We would be better to, sort of just pay for it all and make sure everybody gets the services that they need, instead of doing all this crazy insurance stuff. But we do all the crazy insurance stuff, so we're trying to live in that world.
I know that the federal grant process has a lot of steps to it. Have you acquired that already? Are you through the process?
Oh,
Or is
yeah.
that-
Yeah.
That's all done?
Yeah, that was done
So
years
that
ago.
money's,
Yeah,
Yeah.
I mean, Blackstone's been getting federal grants for 40 years. Most community health centers have their federal grants up and running for years and years. I mean, you have to go through this process of applying and reapplying, and, reapplying again, and, it's like, have you guys gotten the opportunity to mess around with the joint hospital accrediting process? You don't wanna do it if you don't have to, but, there's a process, they send in inspectors, and they check and they double check, and they make you give them all sorts of data, and that's constantly ongoing, and, you can always lose your federal grant if you screw up. But, most community health centers in Rhode Island have been doing this long enough so that we know how to jump through the hoops. And when we get it, we do it right. The idea is that you do it right, and, you provide the best care that's available. It turns out that community health centers provide the best measured primary care in the United States. And part of that is because there's somebody breathing down their names. When I was in private practice, I used to run a big private practice in Pawtucket called Hillside. When I was in private practice, there was nobody breathing down our necks. We could do or not do anything we wanted. We'd like to think that we did it right, but there was nobody checking. Whereas when you're a community health center, everybody's checking all the time, including the Department of Health.
Is that money just for operating expense, or is that for construction of the building?
It's mostly for operating expense. The construction process is a whole different process. There's fundraising and there's a whole different approach to that. Other questions? All right, let me go on. As I said, when you put that all together, that means health professionals know how to start at the beginning when you're hurt or sick. You can listen to what you say and figure out what you can do to feel better and what you want to do to feel better. Oops, I went the wrong way. And it means health professionals who don't limit themselves to fixing one body system, gender, or type of disease, because most specialists restrict themselves to one little piece. My primary care colleagues sometimes call my specialist colleagues partialists, but is what it is. And the same clinician who takes care of one person over many years, so both the person and the clinician know each other well. Often that same person takes care of a whole family and knows the whole family. It means health professionals who organize all or most of the health services that each person needs, who stays with each person and helps you figure out how to choose the other health services you might need. And I would like to introduce my colleague, Larry Warner of the Rhode Island Foundation, who is an EMT, and a fireman. Many of you may know him. He's been a huge help and huge supporter, and I'm glad that you had a moment to join us.
Glad to be able to stop by.
Is there anything you would like to say as we think about really this first major mobile integrated care effort in Rhode Island?
Sure. First I want to say thank you all for your patience and participation in this training. Mobile integrated healthcare is something that's been seeing a lot of uptake around the country. It has a lot of potential to do good for patients, for the community, for the service providers, for EMS providers. I'm retired from Providence, and Providence has a lot of the same frequent flyers that, that experience that a lot of Providence have, but multiplied many times over because Providence is all volume. And there's a lot of potential there and discussions there being discussed about implementing this model in partnership with Providence Community Health Center to help provide better coordinated care, to provide people the care that they need in the best setting for them. And there's a lot of interest, not only locally, but IAFF has wholeheartedly supported the mobile integrated healthcare model. And there are dollars available from different sources to get things up and running. The Rhode Island Foundation has made an investment in Central Falls because we'd like to provide support to improve the coordination of care between EMS and primary care. And there are other communities that are interested in it as well. So we're hoping to see what can be done here. We know that each community is unique, Central Falls is unique. So again, thanks for your participation, and
Thanks.
for your leadership.
Thanks for your help and support. The foundation was really critical in getting this teaching session up and running and helping fund it. So, thank you. Anyway,